Hello everyone, I'm Dr. Bradford and my topic today is neonatal emergencies and their anesthetic management. A big thank you to IT for setting this up for me. In this lecture, unless I say otherwise, pretty much everything I got was from Smith's Anesthesia for Infants and Children, edited by Peter Davis and Franklin Cladis. So let's get started. This is always the call you want to get. There's a baby and they want to go right away. So things we're going to talk about today, kind of the urgency and emergency of some of the important neonatal pathologies. We're going to talk about some of the associated syndromes and talk about kind of the anesthetic goals and management strategies for these babies. So when you get that call in the middle of the night, your first step, always correct, will be to warm the room. It's so important to keep these babies warm. Hypothermia is not your friend, so make sure the isolette is heated when you're transporting them. Bear hugger, or some places use a warm water mattress. Heat and humidify the gases. Plastic wrap from the bear huggers, or just in cath lab and fellowship we used saran wrap. That works too. And make sure to warm your blood, your fluid, and the surgical team should warm their irrigation. Step 2. Just keep in mind some kind of basic pediatric anesthesia ground rules. Babies are very good at compensating until they can't, meaning you have to be quite vigilant and on top of fluid and blood losses because they have a small total fluid volume that even what seems like a little bit can actually be quite considerable. So for a lot of these cases, make sure you have a type-in screen. You won't ever regret having one. Depending on the case and the baby, blood products available, whether you have them ready in blood bank or in the room. There's not really a set threshold for a specific number for hematocrit where the brain is perfused optimally, but generally hematocrit around 40 and higher if the child has congenital heart disease depending on the lesion. No bubbles, no troubles, so that means de-air all your lines, very kind of fastidious and crazy about bubbles because many NICU babies have things like PDAs, PFOs that you don't want to paradoxically send some air to the brain. And typically, if you can calculate the approximate fluid volumes and dosages for emergency meds, that makes it just that much less stressful if things start to get a little hectic and a little hairy. You already know those volumes and dosages that you can just give. The other rule, if the patient isn't dying, don't kill the patient. So this rule basically just means if you can buy yourself time, keep a focus of your priorities, buy yourself time. If the patient's able to ventilate, you're okay. This rule comes into play when you have a child maybe with epiglottitis in the ER and it's, the airway is swelling. That's one of the classic ones where you don't worry about, getting labs or getting an IV or making the child angry with the blood pressure cuff. That's one of those cases where further interventions that delay the primary intervention of securing the airway in the operating room will just get you into a worse situation. And check for associated anomalies. This is very important because although a lot of these defects can occur isolated, meaning the baby has no other problems. Many of them do occur in associated syndromes, whether they're chromosomal or not. So to go right in, our first topic is going to be congenital diaphragmatic hernia. So as you can see on this radiograph, you can see there is bowel in the left chest. So many times these children have cardiac defects. Important to get an echo. They are at very high risk for a contralateral pneumothorax. So if aggressive mask ventilation can be dangerous. The embryology is thought to be around the 4th week of gestation as the malformation of the pleuroperitoneal fold. Most commonly is going to be on the posterior lateral. That's the Bowdlex hernia. It's about 95% of those babies. 80 to 87% are going to be left-sided. Very rare, about 2%, they are bilateral, CDH, Morgani, and which is anterior medial, is more rare. When that happens, it's most frequently identified along with trisomy 21 or Downs. Usually, the sequelae that you will see is varying degrees of lung hypoplasia, varying degrees of pulmonary hypertension, and arteriolar reactivity, which may mean that the child goes on ECMO, and associated congenital anomalies. Many times midline, cardiac, GI, GU, skeletal, neural. Pulmonary hypertension is one of the main predictors of mortality. 1.4% if it's mild, 7.4% moderate, 56% with severe pulmonary hypertension around a month old. The prenatal diagnosis, the presence of CDH on prenatal diagnosis typically means it's a little bit more severe. That's why it's been picked up. That's why you may see that it seems an increased risk factor for mortality. Other things that are bad prognostic signs: lower birth weight and early gestational age, meaning very early preterm. Typically, in modern times, 95% of patients survive after primary repair. If it's a severe defect and they can only do a patch repair, those children have about a 76% survival rates. Typically, that is associated with more pulmonary hypertension, and it's just a more severe lesion that they can't primarily fix it. So in other terms, for survival, if the patient is severe enough to go on to ECMO, 51% of those kids seem to live. If they have complex congenital heart disease, meaning not just a BSD or a PDA, something like a truncus, hypoplastic left heart, or a interrupted aortic arch, along with all those things, that's another independent risk factor for poor survival. Interestingly, we said left side is more common. However, right side is not a risk factor for severity of pulmonary hypertension or mortality. So preoperatively, with a child with a congenital diaphragmatic hernia, usually NICU or in delivery room, the child will be intubated. Newer ventilation strategies are to allow some hypercapnia at the expense of maintaining, aggressive ventilation or very high tidal volumes, kind of a lung protective strategy. NG tube to decompress the stomach. Typically, these children are put on broad spectrum antibiotics and sedation. Goal saturation is going to be around 85% pre-ductal. Correct the acidosis and maintain urine output 1 to 2 mLs per kilo per hour. This is kind of in contrast to previously, many children with CDH were repaired early. That's not always the case now because they've found that stabilizing the baby rather than rushing to OR is associated with better outcomes. So preoperatively, that's happened, and now we've gone down to the OR, we're intra-op. All the standard ASA monitors, plus an extra pulse oximeter, so a pre-ductal and a post-ductal. And the importance of that is because if you start to see a really wide difference in those values, that alerts you to the possibility of pulmonary hypertension, and you may need to start some nitric oxide, which the NICU respiratory therapist typically will bring to the room and have available, or you may need to go on to ECMO. Usually these are done either as a TIVA with the NICU ventilator because you don't have any of the risk of, changing the ventilator over, de-recruiting, and the NICU ventilators usually are able to give a little bit better idea of tidal volumes and actual end tidal CO2 just because of the amount of dead space. They also can humidify the oxygen and air that you're blending in. They have built-in humidifiers and warmers. Usually it's high-dose opioids or moderate-dose opioids with a low inhaled anesthetic agent if you're using your OR ventilator. Kind of the goal is to keep peak pressures around or less than 25, and this really kind of, one of these cases speaks to the communication between you and the surgical team, watching the peak pressures, watching your ventilation, because as they bring the intestines out of the chest, you're going to have changes in oxygenation and end tidal CO2. So post-op, you'll go up to the NICU, intubated. There are some people who prefer to place a caudal catheter. Basically, the goal of this being that you get the baby a little extra non-opioid pain relief, hopefully allow them to extubate sooner and minimize their exposure to opioids in the NICU. This is usually done with an 18-gauge angiocath, and then you thread the catheter up to the level of the incision. That's pretty easy to tell on the baby. You can just measure how many centimeters up from the caudal space and then thread it that far up. With little NICU babies, because bupivacaine and ropivacaine can tend to build up in their systems, after about 24 to 48 hours, you'll want to change that local anesthetic solution from ropi or bupivacaine to chlorprocaine. Our next condition that we'll talk about is pyloric stenosis. This is not a surgical emergency. It is a medical emergency because the child needs to be resuscitated, but not a surgical emergency. The risk of taking a under-resuscitated child to the OR and the induction of anesthesia can cause a very little baby to essentially, you risk cardiovascular collapse in that child. So rehydrate the patient at least 20 mLs per kilo times 2 of crystalloid to get the urine output going. One of the kind of more reliable indicators is wet diapers. You want 1 to 2 mLs of urine per kilo per hour. So once the patient is getting rehydrated, you may see that they're following the lab values. Some people have a cutoff of a chloride of 100 to kind of judge that resuscitation has been adequately achieved. Some people go by a chloride level of 90 to 95. You also want to look at the bicarb and see that that is normalizing as well, that your alkalosis is starting to resolve. So let's say your baby is resuscitated, rehydrated, and they're ready to come to the operating room. First thing after, getting the pulse ox on, this is one of the cases where we will suction the baby awake. It's not nice, they cry and they sputter, but you will be surprised by how much you actually get out. A recent study from 2015, they looked at the gastric volumes of these babies. 83% of them, after being fasted, had greater than 1.25 mLs per kilo of gastric volume. And that's just because the hypertrophic pylorus does not let anything through. So you've suctioned the infant, you turn them on their side, suction them again. At this point, I think it's really important to watch heart rate, because some babies will tolerate this kind of suctioning and not become bradycardic. Some babies do. So let them recover, suction them again. There is some discussion over classic rapid sequence induction with pyloric stenosis babies, which typically in the past meant atropine or glycopyrrolate pretreatment, propofol, or succinylcholine. Very long time ago, they used to do awake intubations for some of these babies, but then they found that that can increase their risk of intraventricular hemorrhage, and it didn't really improve aspiration events. So we don't do that anymore. Whether you choose propofol alone, propofol sucks, atropine propofol sucks. You can also use rocuronium. The benefit of rocuronium is you have no issue with possibly inducing bradycardia, no issue with hyperkalemia, no issue with potentially being a MH triggering agent. But rocuronium tends to last longer, as you know, and then sometimes with these cases being quick, the surgeon is done before your rocuronium has worn off enough that you can reverse. Now that we have Sugammadex, although it's not approved in little babies, in anyone, I think, under 12, I'd have to check though, we have Sugammadex. I don't know if it's worth using Roc-4. Some people don't use any paralytic at all to intubate their pyloric stenosis babies. Sometimes they just use propofol alone. What we do know is that postoperative outcomes tend to improve at specialty centers, even for common procedures like pyloric stenosis. This study also looked at appendectomies. There was a few studies recently that came out around 2015, 2016, where they investigating using spinal anesthesia for babies because of the questionable potential for neurotoxicity from general anesthetics, where they did a retrospective analysis. They did not have any aspirations with the spinal anesthesia group. They took less time to leave the OR, obviously, because the child was not under general anesthesia, but it didn't always work. Of the 12 cases, 3 had to be converted to general anesthesia. There also was a study that came out that looked at potentially doing a gas induction for pyloromyotomy. I'm mentioning this just in case you come across it. They reported, it kind of made a little bit of controversy because they reported they didn't have any aspiration events. And we're always saying we want to avoid aspiration. We do RSI or at least IV induction. So they looked at 269 patients for pyloromyotomies. They did an inhaled induction. Even though these children had IVs, they still did inhaled induction, and they did not record any aspiration events. My thoughts on this are that if you have an IV, I would use it. I still think it's safer to do a quick IV induction than to do a gas induction. And my worry would be that with aspiration being a rare event, if it does happen, it's potentially devastating, and why would I take that risk? But those are just my thoughts. The other thing that is kind of common with these babies is because of the alkalosis, it affects the CO2 shift in their cerebrospinal fluid. Their wake-ups tend to be long. You also typically do not need to give these babies any narcotic. So just two things to keep in mind when you have a pyloric stenosis child. So if we do a couple board review questions, we have a patient with hypertrophic pyloric stenosis, and you get a call. Surgical intern calls the operating room to schedule a pyloromyotomy for a 3-week-old male. Which of the following lab values is most consistent with the patient who has been adequately resuscitated? So looking at this, we can immediately rule out C, because that's a very abnormal chloride level. It's very low. That baby has not been resuscitated. Looking further, we find there are the other choices, a chloride level of 95, of 110, and 110 in option D. However, then if we go look at the bicarb, we have the child who has in choice B a bicarb of 26, in choice A a bicarb of 26, and D bicarb of 17. So that's not normal, so we'll get rid of those two. Moving on, we look at choice A and B. That child is rather hypokalemic and hypernatremic. If we focus on B, we can see that those lab values are the most close to normal, and that's probably the child that is most adequately resuscitated and ready to go to the OR. For our next board review question, which of the following statements regarding infants with pyloric stenosis is true? So if we look at our choices, total gastric fluid volume is 5 cc's per kilo on average, which we've seen evidence from one paper that 83% of pyloric stenosis patients had greater than 1.25 mLs per kilo. Fasting intervals significantly affect the average gastric fluid volume. They do not. Barium from a radiographic evaluation increases gastric fluid volume. Presence of NG tube significantly reduces gastric fluid volume. So A in this question is the correct choice. Moving on to our next topic, necrotizing enterocolitis, or NEC. This is a gastrointestinal emergency of really unknown etiology, multifactorial is what they say. And usually this is going to be a very small baby. Many of these are done up in the NICU at bedside, where the child is usually already intubated and lined. These children tend to be very low birth weight, under 1,500 grams. They're usually born less than 32 weeks. Typically classic neck in the preterm presents between the 1st to the 3rd week of life, not usually associated with other abnormalities, and there's not usually an inciting event. You can contrast that from another neck-like pathology, which is seen in early preterm, near-term children or term, where they have focal perforations, and usually that happens within the 1st to the 3rd days of life, and that can usually be incited by a hypoxic or ischemic event, meaning an apneic spell or a what they refer to in NICU sometimes as a BPD fit, bronchopulmonary dysplasia fit, where the patient becomes apneic and bradycardic and you have a hypoxic event. NEC is known to occur only postnatally. This is not something that is diagnosed prenatally, and interestingly, it's not found in stillborn fetuses. When they say multifactorial, precise etiology is unknown. They believe that it happens because of an abnormal microbial colonization of the GI tract, an exaggerated inflammatory response, which also occurs with disturbance in the microvascular flow and immature GI immunity. So as you can see, you can have these dilated loops of bowel with evidence of necrosis. NEC can be managed non-surgically with gastric decompression and maintaining NPO, kind of an expectant management strategy. Your surgical indications are going to be if you have pneumoperitoneum, perforation, or intestinal gangrene. You absolutely have to. Relative contraindications kind of include things that you would see where the child is going down a path where badness is going to happen. So clinically deteriorating, becoming acidotic, becoming oliguric, looking hypovolemic, persistent dilated loops of bowel on imaging, or portal vein gas. So your anesthetic goals, many of these XLAPs again take place in the NICU. When you get up there, you want to ensure adequate ventilation, ensure that the tube is secured, you have access, you may have umbilical lines available to you. Because you're dealing with extremely small patients, any blood loss is pretty much going to be significant. You will likely need to have blood products available, and not just available, but the cooler right there in the NICU space. Sometimes these children get thrombocytopenic and coagulopathic as the clinical deterioration continues, if they become acidotic. So you want to be able to replace not just colloid or not just crystalloid and fluid loss, but actual RBC oxygen carrying capacity. It's very helpful to know your baseline hemodynamic values. Many times the anesthetic, because the child is usually already intubated, will consist of opioids and neuromuscular blockade. So it's good to know exactly what fentanyl will do to that baby's heart rate and blood pressure. Once the XLAP gets started, usually you're monitoring a UAC if you have an arterial line. You may want to have dopamine and epinephrine drips available and in line in case there is instability. Ensure that the baby is warm. You have a lot of surface area that's relatively exposed because it's a abdominal case. You'll want to replace your volume losses, usually 1-to-1 with FFP and RBCs. Typically, the drugs that you will most rely on for your anesthetic are going to be fentanyl and rocuronium. Post-op, child's going to stay ventilated. The big challenges that remain will be nutrition, TPN, and sedation and analgesia, which usually the NICU will start morphine or fentanyl infusions for these children. TPN will continue until the surgeons are comfortable with letting the child get either breast milk or tube feeds. So now that we've covered neck, we'll talk about some conditions that are associated with syndromes, and the next challenge will be to name the syndrome. It's characterized by hemihyperplasia, meaning you can have one side of the face larger than the other, macrosomia, a large for gestational age child, abdominal wall defects, visceromegaly, including intra-abdominal organs, and macroglossia, hypoglycemia. It's associated with chromosome 11, and there is an increased risk of childhood cancers. So this syndrome is Beckwith-Wiedemann, and just for a little bit of trivia, in the next couple defects that we're going to talk about are abdominal. One of them is an OMPHALOCELE. That, by definition, is greater than 4 centimeters. If the defect is less than 4 centimeters, it is an umbilical hernia, which we see very commonly as well. So defects of the abdominal wall include gastroschisis and omphalocele. Omphalocele is recognized by the sac surrounding the abdominal organs and the intestines. Gastroschisis is the intestines just without any covering. They often look kind of matted, inflamed like that when the child is born. So comparing the two, omphalocele is thought to occur again around the 4th week of gestation. There's one theory that omphalocele is a failure of the loops of bowel to re-enter the abdominal cavity. There's also a theory that gastroschisis is associated with an earlier embryological event and can be traced back to abnormal development in blood supply of the omphalomesenteric artery or right umbilical vein, leading to ischemia in the para-umbilical area on the right side. One more theory, again, we think multifactorial, says that these defects are due to an abnormal relationship between apoptosis and proliferation during embryonic folding. So gastroschisis is not typically associated with any other genetic or chromosomal factors. Omphalocele can be seen especially with oligo or polyhydramnios and chromosomal abnormalities. The defect is at the umbilical ring, and the guts are enclosed with a membrane. The associated problems are going to be cloacal exstrophy, the trisomies, Beckwith-Wiedemann, which we described before, and pentalogy of Cantrell, which is also known as thoracoabdominal syndrome because the defects are mostly midline, and they involve a diaphragmatic hernia, sternal cleft with or without ectopia cordis, which is where the heart is also outside the chest cavity, OMPHALOCELE, pericardial defects, and potential intracardial defects, including VSD, left ventricular diverticulum, and tetralogy of Fallot. Okay, so preoperatively for abdominal wall defects, the goals are to minimize heat and fluid loss. Typically, unless there is a maternal indication, the babies are kind of allowed to be born by vaginal delivery. They may be C-section, they may not, but usually right after delivery, they are covered and cleaned off a little bit. There's really important not to, for gastroschisis babies, twist at the stalk because that can cause ischemia to the intestines, but they're covered and cleaned. They need an IV for sure. Rehydration can mean up to 3 times daily maintenance rates. Broad spectrum antibiotics to prevent/treat sepsis. Carefully monitor electrolytes, and goal urine 1 to 2 mLs per kilo per hour. Intra-op, when these babies come for repair, gastroschisis is typically repaired earlier. Sometimes for very, very large omphaloceles, they may allow the baby to go a few days, even a week or so, to allow the omphalocele almost to kind of epithelialize to improve the repair. Still watch pre and post ductal sats, plus minus arterial line depending on cardiac status, plus minus neuraxial, similar rationale for the CDH repairs. If you can pass a caudal catheter, you can potentially decrease the baby's exposure to opioids. Another reason you have to know the associated defects, because if there's anything wrong neurologically or in the spinal column, tethered cord, then you can't do it, obviously. With both gastroschisis and omphalocele, there's a risk for abdominal compartment syndrome once the defect is repaired and the intestines are back in the abdomen. Sometimes with gastroschisis, they will place a silo, which looks kind of similar to a plastic flexible cylinder, and gradually reduce the contents. Another point where you have to really watch your inspiratory pressures to make sure that you can still ventilate when the defect is closed. They may place a central line for TPN, and again, you're going back up to the NICU intubated. So next up, another name that syndrome. I took these pictures off of a parental blog, so I'm assuming that gives me permission to use them if they put pictures of their kid on the internet. So I don't know if you can see quite so well, but you can see there's some radial anomalies here. You can also see it on this side. This syndrome is also associated with cardiac, renal, vertebral anomalies, so basically it's bacterial. V vertebrae, A for imperforate anus or atresia, C cardiac, TE for tracheoesophageal fistula or esophageal and duodenal atresia, renal anomalies, and then L they add for limbs, including radial agenesis. So that brings us to our next topic, which is tracheoesophageal fistula. This type C is the most common. It accounts for 90%. In babies that are born with types A and B, where the esophageal anastomosis is going to be much longer, you may see varying surgical approaches. If this is done thoracoscopically or open. And babies with type E who only have stenosis may only need to undergo serial dilations. It just kind of depends on the degree and the severity and how much the esophagus has actually grown. So one suggestion that the textbooks say is maybe this should actually be thought of as a general foregut malformation, because many have associated lung anomalies like lobar, bronchial agenesis, pulmonary hypoplasia, and then up to 50% have these other anomalies like duodenal atresia, jejunal atresia, chromosomal, neurological, or congenital heart disease. Another one of these where the etiology again is uncertain. There's one theory that says that the tracheal, what becomes a trachea, the primordium, buds off too early off of the foregut, or the other thought is maybe the septum, which is supposed to grow in the mesenchyme and divide the trachea and the esophagus, doesn't do that the way it's supposed to. But either way, we see these children. Main associated syndromes: Vactral, several trisomies including 13, 14, 18, DeGeorge, Downs, I guess I could have put that as trisomy 21, and Potter syndrome. Potter syndrome is one that is quite rare. It's uniformly fatal because it's a bilateral renal agenesis. Those children have a very poor prognosis in the rare event that they are born alive. Risk factors and kind of stratifying these babies. Survival really depends on birth weight and congenital heart disease. There was another risk stratification scheme where they also looked at presence of pneumonia and need for ventilator support, but that wasn't found to be quite as consistent and predictable. So group 1, these are updated survival numbers from 2004. The grouping originally came out by Spitz et al. In 1996, but if you're 1,500 grams, have no major cardiac anomaly, those children have a very good chance of survival, 98%. Less than 1,500 grams or a major cardiac anomaly, 82%. Less than 1,500 grams and major cardiac anomaly, survival goes down to 50%. Preoperatively, the goal is to protect the lungs. So the TEFs which occur with esophageal atresia, you'll notice, and kind of the classic question is, the baby is born and they can't pass an NG tube, and they have a lot of secretions that they can't manage. That's your kind of key in for this is a TEF type of question. So keep the child NPO. They are kept upright, semi-prone, basically to allow the secretions to drool out rather than go into the lungs and aspirate. Suction the esophageal pouch, IV access. Sometimes, but not very often, these children may have a gastrostomy tube placed early. It doesn't always happen though. It just depends on clinical condition. Main thing is to along with your other testing to make sure that an echo is performed. This will rule out, one, a right-sided aortic arch, which will change the surgical approach, and it will identify any congenital heart disease that may be present in this patient. Intraoperative goals, mainly, again, ventilation, all your ASA monitors, plus that other pulse ox, a pre and a post ductal. Cardiac status and overall clinical condition will determine if you're going to place an arterial line. Try to maintain spontaneous ventilation. Sometimes the surgical team will do a bronchoscopy before to visualize exactly where the fistula is. They may also place a gastrostomy prior to the repair because this allows you to vent the stomach. And if you do have to do mask ventilation, you aren't just going to keep inflating the stomach to the point where it restricts lung excursion. If the fistula is below the carina, you can just main stem the tube. If it's above, intubate, and for an open repair, they can retract the lungs. Sometimes you may read about, positioning the bevel of the ET tube away from the fistula so that you can ventilate without insufflating too much. The practicality of that is its own. Typically during lung retraction for these thoracotomy procedures, you will see changes in your ventilation. If you see the baby start to deteriorate, you can ask the surgeon to let go while that lung expands and then continue on. One of the things, depending on which group this baby is in, 1, 2, or 3, and if they have associated cardiac anomalies, is to see if the baby can even tolerate one lung ventilation. It isn't always the case, and in that case you would just leave the tube kind of in a standard position and resume 2 lung ventilation. Postoperatively, if you hadn't noticed a theme, up to the NICU intubated. Depending on the length of that esophageal anastomosis, the child has to be mechanically ventilated for at least 24 to 48 hours. Sometimes the surgical team, before leaving the operating room, will ask for or will themselves place an OG or an NG tube with specific instructions not to manipulate it, because that's what is through the newly anastomosed esophagus. Depending on how long the child stays intubated, you have to think about sedation and analgesia. Also, with hemodynamics and making sure the child is comfortable enough not to pull at the tube, they may do a neuromuscular blockade. Since survival has improved so much, especially those children in group 1, we can talk about postoperative outcomes. Typically, down the road, you may see a child who has had a TEF repair, who may come for dilations of the esophagus if there is stenosis. Child may also come for feeding tube placement due to developing oral aversions or esophageal dysmotility. Sometimes their lung manifestations include restrictive and obstructive lung disease, and they may also have tracheo or laryngomalacia. You may see, if the child is intubated for an extended period of time, develop a subglottic stenosis, the way babies intubated in the NICU for other conditions for a long time may do. Our next condition we're going to talk about is associated with this syndrome, which includes micrognathia, cleft palate, downward slanting eyes, and choanal atresia. This is a picture of 2 people with Treacher-Collins syndrome. As you may guess, it's a risk factor for having a difficult airway. The man in that picture actually is a patient advocate, and he does travel and give talks. He's been on like the cover of People magazine, kind of raising awareness for Treacher Collins and associated facial syndromes. So our next one is bilateral choanal atresia. The baby will present with airway obstruction, stridor. Females are affected more than males, and paradoxical cyanosis, because you learn that neonates are typically obligate nasal breathers. These babies actually become pink, and they improve when they cry and scream because they start to suck in air through the open mouth. A couple different surgical options are available. They may be resected, transnasal, or transpalatal puncture with or without stenting placed. Unilateral typically can wait. Bilateral has to be an early operation to establish an airway. IV induction is preferred, and typically you will need an oral airway because babies are known to obstruct on induction. They have large tongues, they have large occipits, and you don't have the nasal passageways as a way to ventilate them, so you have to relieve that obstruction. Always have an oral airway. Associated syndromes other than Treacher Collins, charge, which is colobomas, heart abnormalities, choanal atresia, growth or mental retardation, GU, and ear abnormalities, or Cruzon, which is a facial abnormality syndrome, kind of similar to Treacher Collins. Otherwise, you can intubate with an oral ray, inhaled agent, or TIVA, and then the surgeons may use mitomycin C to prevent restenosis in the newly open nasal passages. That's all I really have about choanal atresia. Next syndrome that we're going to talk about is associated with our next neonatal condition. It's enlargement of the fourth ventricle into the posterior fossa. This is Dandy Walker. Chiari is where the cerebellum herniates inferiorly, and that blocks CSF. Tethered cord, these are all associated with spina bifida and myelomeningocele. Spina bifida is kind of the big umbrella term. Meningocele occurs if no neural tissue is present in that sac. If you have neural tissue, it's a myelomeningocele. If you don't have a sac and it's just neural tissues, it's a rachis, which is very rare. Usually associated with hydrocephalus because of the risk of damage to neural tissue and infection. This repair occurs day 1 or 2 of life. These babies may have reduced ventilatory responses to the point of an absent ventilatory response to hypoxia, especially if a Chiari malformation is associated. Primary concerns are with positioning and not putting any pressure on the sac because you don't want it to rupture. Intubation can occur depending on the size, either supine, where you use the donut to place it where the sac is and intubate supine so that the baby is not actually laying on that exposed tissue, or lateral, where you position the baby on the side, induce, and intubate. Otherwise, intraoperatively, because it's a large area, the child is prone, you want to make sure the child is warm and watch EBL. Again, these children don't have a lot of volume, so any blood loss can be pretty significant. Secondarily, your concern is to minimize latex exposure. Many of them go on to develop a latex allergy. Once they develop a latex allergy, they are at risk for developing allergies to further medications, cosmetics, foods, substances. Usually, again, these babies go intubated to the ICU once the defect is repaired, just because their ventilatory responses, one, they're neonates, and two, they've just had neurosurgery. So typically we don't extubate them. All right, so now that that's done, I have a couple of questions, more PEDS boards review questions. These are pretty general. One I think is related to pyloric stenosis. So which of the following factors is least likely to influence the incidence of post-op nausea and vomiting in a 5-year-old? Going through our choices, antiemetics, those will help. History of motion sickness, that is a risk factor. Type of surgery, ear and eye surgeries are more nauseating than other types. Gender is least likely, that's our answer, because gender really comes into play after, like, right around puberty and then into adulthood. That's when women tend to have more post-op nausea and vomiting than do men. Next question. So we have an 8-week-old child for inguinal hernia repair, bilateral, and circumcision, feeding and growing well. Sounds like a healthy little guy. Which of the following parameters is most important in predicting his risk for postoperative apnea? So hematocrit is 1, that is a factor. Anemia is an independent risk factor for apnea, but it's not our most important. Preoperative oxygen requirement, also a risk factor, but not most important. Birth weight tends to correlate with gestational age, but birth weight can be affected by a lot of factors, including associated syndromes, maternal substance or drug use. Post-conceptual age is the most important one, because a child born at 32 weeks, who is now 8 weeks old, corrected age is only 40 weeks. However, a child born at 38 weeks, now 8 weeks old, so corrected age is 46 weeks, their risk of apnea post-operative after a general anesthetic, fentanyl, narcotics, or not, is going to be different. So your answer is C. Very last one. Which of the following is not a risk factor or an associated factor of pyloric stenosis? Caucasian ethnicity, female sex, early preterm birth, and maternal smoking. So typically these children are male. You have a greater male predominance than female. Caucasians are affected more. Early preterm birth and maternal smoking are all risk factors. Thank you so much for your attention. I hope this was helpful to you. If you have any questions about anything I talked about, feel free to email me. And again, a big thank you to IT for helping me record this presentation.